objectives that we have today. So we're talking about what an opioid is. We're talking about risk factors for opioid poisonings and strategies to minimize them. And then finally, we're going to talk about responding to an opioid poisoning. And in creating this presentation, I was really hoping to focus on the why of all of these things. So whether as the healthcare worker, you're educating clients on harm reduction techniques or strategies to respond, or the opioid poisoning itself, I hope we can talk a little bit about why we talk about each factor. All right, so what is an opioid? So as I go through these kind of multiple choice options, you can think to yourself which one sounds like an opioid. So is this a category of molecule naturally found in the opium poppy plant? Is it a type of unregulated drug which may induce euphoria or feeling high? Is it a class of pain relieving medications that are prescribed? Is it a substance which may also be referred to as a narcotic? Or is it a substance which may result in a use disorder or an addiction? And final option being all of the above. And of course, as many of you know, it is all of the above. So, teasing out all of these different explanations for what an opioid is, I think is where we can get a little bit muddled and where a lot of overlapping perspectives and education can become a little bit confusing. But really, an opioid is all of these different things. All right, so what drugs are considered opioids? So there's many names, and this list is by no means exhaustive. But on the left, we have molecule names or the names of prescription medications. And then on the right, we have what they might also be referred to as. So whether this is the brand name, a different name for the molecule, or what we call maybe street names, things that I've heard these drugs referred to as, or things that I found online. So pretty overwhelming list of names. And again, this changes geographically, and it changes through time. So hard to keep up with. So definitely a lot falling into this category. All right, so the opioid poisoning crisis. This is a crisis that you might have also heard referred to as the opioid crisis or the opioid overdose crisis. What is it? At its core, it's a significant and really devastating increase in the number of opioid-related deaths that we're seeing in our communities. So the graph that I've pulled here looks at the Ontario opioid-related deaths over the past roughly 20 years, right up until last year. And as we can see, there's been a almost exponential increase, really devastating increase in the number of poisonings. And I chose to present the Ontario data, but really, I could have chosen Toronto data or Canada or another province because at a different scale, this is really the trend that we're seeing across jurisdictions. Probably also, the trend maybe in your neighborhood that's being seen. All right, so why is this happening? And when I speak about the why of this, I'm going to be talking about by and large, the strongest reason for this significant increase, and that's the unregulated drug supply. But I want to acknowledge when I talk about this why that there are other reasons. There are other instances and situations where someone might experience an opioid poisoning, but we're going to be talking about the main driver about the trend that we're seeing. All right, so what we're looking at here is samples from a lab. So on the left, we have heroin, in the middle, we have fentanyl, and on the right, we have carfentanil. So these are all opioids, and the amount in these vials represents the amount that could result in a poisoning for someone. So as we see, the amount gets infinitesimally smaller as we go towards carfentanil. And so the first reason that we're seeing all of these poisonings is because as fentanyl has entered the unregulated drug supply and subsequently carfentanil has entered, really the margin of error for opioid poisonings has become incredibly, incredibly small. So that's a first reason why we're seeing that devastating trend. Another reason for that trend is due to contamination. So what are we looking at here? So this is from Toronto Drug Checking Services. So this is the last 820 samples that they have tested where someone presented them what they bought as fentanyl. So they said, I expect this to be fentanyl, and then Toronto Drug Checking Services checked it for them. And in the vast majority of samples, 80%, fentanyl as well as other drugs were found in those samples. There was actually no fentanyl whatsoever found in 16%, and only 4% of the samples were purely fentanyl. So what exactly was contained in those samples? Many things. Some of them we're familiar with, like the top one, caffeine, as a cutting agent. Many of them we're not familiar with, or we know roughly what class of medications they're in, but we really don't know the effects that they might be having. So this contamination piece is, of course, another reason why that opioid-related mortality has gone up significantly, because of these other substances that can contribute to poisonings. And I think I really endeavored to answer a lot of why questions during this presentation. And I think one of the most common why questions that I get when I speak about this is, why is there such a high margin of contamination? And I think that that's one of those questions that doesn't have a good answer, or I certainly don't have it. There's a lot of factors, including the lack of simply regulation and quality control on an unregulated market, as well as cost cutting. Additionally, supply chain issues have come up during COVID-19, as we all know, with every market, and the unregulated drug market is no different. So various factors are feeding into this. And important to note as well, it's not just fentanyl supplies, it's also the rest of the unregulated drug market. So here we see the Toronto Drug Checking Services last 575 samples of what people expected to be cocaine. And a significant portion, 33%, contained cocaine and other drugs, and 4% contained actually no cocaine whatsoever. Again, same with methamphetamine. So no methamphetamine found in 11% of samples. So bringing it back to that image that I displayed earlier, where we had fentanyl, heroin, and carfentanil, in the unregulated drug market, it looks a little bit more like this. So we don't have these nicely tested, individually sealed bottles where we can see exactly what's inside of it. Really, the difference between something that might have no effect and something that might cause an overdose is completely unknown. So whatever these vials might be, someone might think that they're buying fentanyl and they might not know whether it's heroin or carfentanil, or they might think it's cocaine, and there's just a lot of unknowns. And both people who are buying don't know what they're buying, as well as people who are selling really don't know what they're selling. Okay, so I hope I've impressed upon everyone that the landscape is extremely risky. So as individuals, as citizens, people using drugs, or people educating and speaking with people using drugs, how are we going to help minimize the risks associated with this? So I've listed 5 harm reduction tips here. These are by no means the only harm reduction tips out there, but there are kind of 5 of the common ones that I will rattle off. So we have never use alone, be aware of loss of tolerance, use a test dose, avoid mixing substances, and finally carry naloxone. And I know that for me, I get comfortable rattling these off, but I want to talk a little bit about why we recommend each one of these tips in practice. Oops, let me go back there. All right, so the first tip is never using alone. So why should someone never use alone? So the theory underlying this harm reduction tip is that if someone else is physically present with an individual using drugs, they're there to respond. So whether that be respond with naloxone, respond by calling EMS, and we'll go into the tips about responding to an overdose later, there is someone there who can address the situation. We think about someone using alone in their apartment with the door locked, maybe you need a buzzer to get upstairs. maybe no one even knows that person's using, the risk of death associated with an opioid poisoning is going to be much higher. So listed here is just one slide of this comic that I will circulate after the presentation and is listed at the slides because I think it's a great little comic book. But we see someone entering here who's calling their friend and asking that person to spot them over the phone. And then the friend is just starting to ask some follow-up questions. So, phone calls, FaceTime, or being in person are all options. In person is ideal because it's the best way to respond, but any of these are better than using alone. And then just highlighting here that in Canada, we do have the National Overdose Response Service. So this is a 24-hour free phone line where individuals will spot you if you're using drugs and respond if needed, if you stop responding. Okay, so the next harm reduction tip is loss of tolerance. So what do I mean by loss of tolerance? The idea of tolerance is that if you're using a substance consistently over an extended period of time, you're going to require more and more of that substance to achieve the same effect. Loss of tolerance is when you then have a period of abstinence or a period of using no or less of the substance. And so when you return to using the same amount that you used before, it affects you much more significantly and in fact increases the risk of poisoning. So we should be aware of this because it is under-recognized. I think it's under-recognized by people using drugs as well as healthcare workers or anyone working with anyone who uses drugs. Because really, this happens extremely quickly. This happens on the scale of a couple of days. So if we think about the different reasons why someone might lose tolerance, we can think about a period of abstinence that they have, self-motivated or desired to take a period of abstinence. It can also be because of an institutionalization, so an incarceration or a hospitalization. It can also be because of a vacation where they don't have access, or just because they happen to not use for a little while. So I think it should be something that we all try and keep on our radar and keep in mind. So once we're aware of loss of tolerance, how do we address that? So one of the ways we can address that is using a test dose. So because tolerance is a moving target, and this is not just following periods of abstinence, but always, somebody should use a test dose. So whether I'm getting a new supply, or maybe I've changed, or maybe I'm ill, maybe I've undergone a period of abstinence, or maybe just as regular practice, it's probably best to use a small amount of your drug sample before moving on. As we know, and as we discussed ad nauseum, the contents and the strength of the unregulated market is extremely unpredictable. So the idea of using a test dose is that it can provide some insight about the supply and how you will respond. And the reason I emphasize some is because test dose is not a perfect solution. And bear with me here because this is a bit of an extended metaphor. Because when we use a test dose, we should still proceed cautiously. So we're going to look at this chocolate chip cookie and we're going to think about it as a drug sample. So let's say this is some fentanyl that I've picked up and the chocolate chips are carfentanil. Or let's say this is a cocaine sample that I picked up and the chocolate chips are fentanyl, or any other combination of substances. So someone using a test dose might use this small amount here and get one little chocolate chip and might respond in a certain way and think that that is the way that they're going to respond to the whole sample. However, it is not uniformly mixed. And the next sample that they use, because they listen to my harm reduction tips and they're proceeding slowly, they use another small amount. And in that amount, there might be more of that unpredictable strength or unpredictable contaminant. So really just this metaphor is being used to show us that we should always proceed cautiously and slowly because the contents of a sample might even be unpredictable within the same sample itself. The next harm reduction tip is that it's best to avoid mixing substances. Few reasons for this. The first reason is interactions. And sorry, I should explain what I mean by mixing substances first. So this is using two different substances on the same day or event or evening. So, one might be unregulated and one might be regulated, or both might be unregulated, or any number of combinations, but really kind of two psychoactive substances. So what I mean by interactions is that one substance might affect how the other one interplays in your body. So it might increase the concentrations, it might change how it's metabolized. They can have a number of funny effects on each other. And I also mean that the way that one affects you, such as decreasing your level of consciousness or increasing your level of consciousness, the other one might have the same effect. So they can kind of add to each other in the way that they affect your body. Also, again, as we talked about, and I keep mentioning, things are contaminated. So even if we're expecting that we're using substance A and substance B, we actually might be using substance A, B, C, and B, C, D. So there might be a variety of contaminants in what we're using, and we might not expect that they actually contain the same things, but they might. And finally, 1 + 1 does not equal 2. So just because I might have one effect to the substance on my left and another effect to the substance on my right, doesn't mean that when I use them together, those two effects will just happen at the same time. It's actually going to be likely an entirely new effect that those two things together have. And the last harm reduction tip is why we should carry naloxone. By and large, it's because naloxone is a great tool that can save a life in the event of an opioid poisoning. It's also free. So, ideally the barriers are minimal. And linked at the end of this presentation is a map where you can actually enter your postal code and it'll show you the closest pharmacy that dispenses naloxone. So ideally, barriers are minimized and it's a great tool. So we're going to talk a little bit more now about the process of responding to an opioid poisoning. So this is a naloxone nasal spray kit. You might also hear it referred to as Narcan. That's the brand name for the nasal spray. So as we see here in the kit, we have 2 nasal sprays. There's an instruction booklet on how to respond. There's some non-latex gloves. There's an ID to show who's been trained. And there's a breathing barrier device. What we see here is the injectable naloxone kit. So these were more common before. However, the government is now funding the nasal spray, but the injectable kit is still available. So what is contained in this kit is 2 needles and syringes, 2 vials of the naloxone, 2 alcohol swabs, again, the breathing barrier, again, the non-latex gloves, the instructions on how to respond, and a card identifying the person who's been trained. So who's eligible to get one of these free naloxone kits? So this is the wording used, in the Ontario scheduling. So you're eligible if you're at risk of an opioid overdose. So this is anyone who's using an opioid that's prescribed to them, anyone using an unregulated opioid, or anyone really using any other unregulated substances, because as we've seen with the contamination, those might also contain opioids. Also eligible for the free kit is any family member, friend, or other person able to help someone at risk of an opioid overdose. And I would argue that as people who are, citizens of, the city and walk around and interact with people, I would argue that anyone really could fall into the other person able to help someone at risk of an opioid overdose. So let's talk a little bit about what the symptoms of an opioid overdose look like. So if someone's experiencing an opioid poisoning, they'll be having slow breathing, slow and shallow, or no breathing whatsoever. They would be unresponsive, so unconscious, so that's to voice when you call at them, or pain, maybe a pinch, can be woken up. They would have a pale face, blue lips or nails, and if someone has darker skin, this might look like blue gums. They would have gurgling maybe or snoring sounds. They might be choking or vomiting, cold, clammy, or damp skin. The next point is tiny pupils. What we say is pinpoint pupils, and that one is quite specific to an opioid overdose, whereas the other ones, a little bit less so. And then a stiff body. And recognizing these symptoms, I have found actually, and as I reflect and as I, go about my life and walk around the city, I find that sometimes I might come across someone that might be demonstrating some of these symptoms. And I tend to have maybe a hard time telling whether that person is resting or sleeping, or I need to be responding. So, just when I'm taking a walk down the street. So really when this has happened, the best first thing to do is, of course, if you feel safe and you feel like you're safe enough with another person or there's people around and you feel able to respond to the situation, first and foremost is really assessing whether someone is breathing. Because if they're having regular deep breaths, it's likely not that they're experiencing an overdose. And also important to remember is that anytime we are responding to an overdose, or we might see someone exhibiting these symptoms, keeping in mind to take a trauma-informed approach. So when speaking to someone, speaking from far away, introducing yourself first, saying, my name is X, I've noticed that your breathing is shallow, I want to make sure that you're okay. And really speaking through what's happening. So the next step, whenever somebody is not responsive, whenever someone's unconscious, is calling 911, of course. So naloxone is a great antidote for opioids. However, it can wear off with time and an overdose can reoccur. So that's why it's important to call 911. Of course, interaction with law enforcement can be, quite fraught. One of the things that I want to turn your attention to is the Good Samaritan Act. So this act essentially protects an individual responding to an opioid poisoning from any legal ramifications of either possessing unregulated drugs or using unregulated drugs. So you're essentially protected from getting in trouble if you're responding to an opioid overdose. All right, so this person is demonstrating signs and symptoms of opioid poisoning. We phoned 911. Next is to assess if they're breathing. So if they're still breathing, we go ahead and we put them in a recovery position, we monitor breathing, and we wait for EMS. If not, or if they're having very shallow breaths or that gurgling sound, we proceed to step 4, which is administering naloxone. So shown in the photo here is how the nasal spray actually goes into the nose. Each nasal spray delivers 1 dose. And Daryl has just posted a training video into the chat. It'll also be at the end of the slides, which actually goes through exactly how to administer the naloxone, both the nasal spray as well as the injection formulation. Step 5 is to give CPR. So giving chest compressions or full CPR with rescue breaths if you have been trained for 2 to 3 minutes. And then finally, as mentioned in what's in the kits, there's 2 doses available in each one. So if the person is still not responsive for 2 to 3 minutes, it's time to give the second dose of naloxone. A few reasons why we give the second dose of naloxone is sometimes, 1 dose is just not enough to block the opioid. and as well as what I mentioned with naloxone's ability to wear off. So I've listed some frequently asked questions about naloxone here in the slides. I won't go through them, but the slides will be circulated. And as well as some additional resources for everyone. So that naloxone training video I mentioned, and that interactive map I also explicitly mentioned on where to get a naloxone kit. All right, and with that, I think we can open it up to any questions that people have. Yes, absolutely. We can flip back to the FAQ slide. Oops, sorry, Anna, I think I stole it from you there. I'm not sure if someone had a specific follow-up question for these FAQs or if they just wanted to go ahead and read through them. So maybe I can read through them quickly. So the first question FAQ is whether naloxone will help someone if they've overdosed on a different substance, so something other than opioids. The answer is no, because it's an opioid blocker. So it really works to reverse the poisoning of an opioid. The next question is, so if you don't know what the person's used, should you just administer naloxone anyway? The answer to that is yes, because naloxone is a very safe drug and it won't adversely impact someone if they are happening to experience an overdose from another substance. Can someone overdose on naloxone if given too much? No, they cannot. However, if someone is an opioid user, they might experience withdrawal from naloxone. I think someone just asked a follow-up question in the chat, so I'll open it up here. My question is covered in the second part. In my experience, I was hesitant to provide naloxone as I wasn't sure. Yeah, so absolutely, like that's very fair because it's a tool to reverse an opioid poisoning. A lot of individuals have that question where they're not sure if they should use it, if they're not sure what's going on. But yeah, it's not going to adversely affect someone if, let's say, they're overdosing on alcohol. So definitely always something that's good to give if they're demonstrating really any of the symptoms that we discussed. All right, I'll just mention the last two here as well. Can expired naloxone still be used? Yes, if it's the only thing available. However, you want to make sure that you write down the date of expiry and replace your naloxone kit when it is expired, because the efficacy of naloxone might start to decline past the expiration date. And in terms of the difference between the injectable naloxone and the nasal spray of naloxone, there's no difference in efficacy. It's really just about, what the person has on hand or what that individual is more comfortable using. So I'll go back to the questions here. I think a couple people have asked them. So there's a question here about the safe number for people to call when using. So it's actually, and whether it's for Ontarians or just people in the GTA. So it's actually a national opioid response or overdose response service. So it's Canada-wide. It's a 1888 number, I believe. I will go ahead and copy the website. It will be in the circulated slides on the resources page. So I've just pasted that into the chat. So someone's asked a question about whether any of the information changes for teens or if there's anything different that needs to be done. So the information for teenagers and children is the same. So in terms of the symptoms of an opioid poisoning and how to respond, including the administration of naloxone, with one small caveat, and that is that the nasal spray of naloxone is technically not approved for children under the age of 2. So if anyone has an individual who's an infant at home and is looking to have naloxone on hand, we might recommend the injected formulation. However, if a situation is occurring where an infant is experiencing a poisoning, I would recommend administering any naloxone that you have on hand. Oh, and Yana found a video version of the comic that I shared, so that's fantastic. I didn't know that was out there.
Neither did I.
That's great.
There's a
I
question
think the
from
comic's available in French too.
yeah. There's a question that from Sarah. If I'm on the road harm reduction outreach, can I keep naloxone in my car? I assume that's a question around like will maybe like heat degrade it or something.
Sorry, Yana, you're cutting out for me a little bit, but I think I heard what you said. So in terms of heat, we do want to ideally keep naloxone at room temperature. So if you're a harm reduction worker that regularly spends time in your car in, summer months or winter months, so in Canada, pretty much all year, I would recommend bringing it inside the house each evening, or if you're going in anywhere. So keeping it in a purse or a backpack is ideal because to maintain stability, it's really supposed to stay at room temperature. Again, if you do have a kit that's been exposed to heat or exposed to freezing and it's all you have in a situation, still administer it, but if at all possible, you do want to keep it within that room temperature range. Sorry about that, Yana. And I hope I'm not cutting out for anyone. But her question was about aftercare. So the best practices for staying with the person we've administered naloxone to and what we can expect. So a few notes about this. So once we've administered naloxone to the person, we want to proceed with chest compressions or CPR. And at the point that we've administered naloxone, we will likely still be on the phone with the 911 operator who would likely be guiding us through the response. If not, we do proceed to chest compressions. However, if the person does start breathing, we can put them in the recovery position. So that looks like a fetal position on their side and monitor their breathing. We put them on their side because they might experience vomiting and we don't want anyone to choke on their own vomit. So putting them on their side is best practice. And in terms of what we can expect, it's definitely varied. So some people might respond to the first dose of naloxone and resume breathing and even responsiveness at that point. However, some people might require both doses or both doses you've given as well as doses EMS will give when they arrive before they actually start to respond. So Andrew's asked the question, are there any other drugs mixed into opioids that will make the use of naloxone ineffective? So thinking specifically about benzodiazepines. So you're absolutely right in that we are seeing a contamination of the opioid unregulated drugs out there with things like benzodiazepines. And you're also right in thinking that if someone's experiencing an overdose, specifically to the benzodiazepines in the drug supply, naloxone won't be effective. But it brings us back to a previous question asked in that even if you're not sure, whether it's the contaminant or the drug itself causing the overdose, always best practice just to give naloxone because if they happen to be having an overdose that's also potentiated by the benzodiazepines there, giving naloxone won't hurt. So yes, it's unfortunate that naloxone only responds to the opioid involved, but still always best practice to give it. And also likely that it'll be at least partially effective. What is considered for room temperature? I can get back to this question because I know it lists the exact range of temperatures specifically in the drug information, so the monograph of the drug. But I would say, any kind of room temperature range that you can assume is probably fine. In terms of the maximum dose of naloxone, so there's no maximum dose of naloxone. Someone cannot overdose on naloxone. So when someone presents to a hospital, they actually might be administered several doses of naloxone in order to reverse the overdose. And that significant amount of naloxone is not going to have a bad effect. So the next question from Brenda is whether it's recommended to put a mask on the person or something over their nose and mouth while performing chest compressions, since chest compressions are considered to be aerosol generating. So I know that there was specifically some changes in the recommendations surrounding CPR response during COVID-19. And I think that change was that they didn't recommend rescue breathing and they just recommended chest compressions. I think this is a really interesting consideration. I would worry that something being over the person's nose and mouth would actually prevent them from resuming breathing, which the chest compressions are trying to do. So yeah, if there's a mask or something that can be easily breathed through and it's on hand, I think that would be a great idea. But I think anything that would occlude the nose and mouth would be something that we would want to avoid putting on top. Daryl asks whether naloxone can be harmful to someone or whether it can be abused or, I guess, result in a substance use disorder. So it can't be. When we say harmful, so the only way that someone might really react poorly to naloxone is if they have an allergy specifically to naloxone. It's very rare that this is known by someone, and it's rare that it occurs, so it should not be something that stops anyone from giving naloxone. And another situation that might be, considered a little bit harmful is that if someone is a regular opioid user and has, a tolerance to opioids, and they're administered naloxone, that might result in some uncomfortable feelings of withdrawal for them. So of course, we're always thinking about the risk of these uncomfortable withdrawal feelings balanced against the risk of death secondary to poisonings. So again, for both of these kind of harmful considerations, I would again lean on administering naloxone whenever we think that someone might be experiencing an overdose. Oh, perfect. So John sees on his kit that it's 15C to 25C. So it's a little bit of a wider range than I thought. So yeah, so anywhere kind of within that room temperature range. How long does naloxone work in the body to reverse the effects of an opioid poisoning? So I believe the duration is about 20 to 30 minutes. It can vary person to person, and it can also vary with the type of opioid that they were using. So whether that opioid was a short-acting opioid or a long-acting opioid will change how long naloxone will work for. So around 20 to 30 minutes, but again, really important, even if that person has responded, has begun to breathe, or is now responding to voice, that overdose might always reoccur. So they might go back into the opioid overdose when the naloxone wears off, if the opioid's still around. So always important to have kind of that follow-up medical attention, even if they've responded. So Chevy is asking if there's a site or location that can be used to trade in expired naloxone, and how should it be discarded? So at the end of the slides that will be circulated, as I mentioned, there's that map where you can enter in your postal code, and it'll show you the pharmacies that dispense naloxone, or public health units as well, I believe. So any of those sites should take back expired naloxone kits and dispense a new one. So you can always give it to them for safe disposal. Also, you can also just present to them and mention that your naloxone kit at home is expired, and they should provide you with a new kit then as well. And then whenever you're near a pharmacy that does any discard or take back programs and it's convenient, you can drop off the expired naloxone kit. So you don't necessarily need to trade in the expired one to get a new one. Yeah, so anywhere that takes back any expired medications or does any disposals should take back expired naloxone.